Hello, this is Joshua Kane. I'm the W.W. Knight Pharmacy resident, and this is part 2 of our diabetic emergencies. In part 2, we'll be discussing the hyperglycemic emergencies, and those two emergencies we'll be discussing in depth are going to be DKA, or diabetic ketoacidosis, or HHS, hyperosmolar hyperglycemic state. On this online lecture, we will go over the pathophysiology and the differences between DKA and HHS. We'll also go briefly over the treatments. In class on February the 20th, we'll go more in depth about treatment and prevention of DKA and HHS. So if you have your lecture notes in front of you, you can see that our objectives for this lecture are you'll be able to define the pathophysiology of diabetic ketoacidosis and hyperosmolar hyperglycemic state. You'll be able to describe the complications associated with DKA and HHS, identify the causes of DKA and HHS, and then in class we'll do some assessments where you'll be able to actually assess the patient labs and determine if it's going to be DKA or HHS. Then you can formulate a treatment plan and a monitoring plan for DKA and HHS, and you'll be able to identify how DKA and HHS can be prevented. Remember, when talking about hyperglycemia, that it is defined as either having a fasting blood glucose of greater than 130 milligrams per deciliter or having a 2-hour postprandial blood glucose of greater than 180 milligrams per deciliter. Remember that hyperglycemia we worry about in type 2 or in all diabetic patients because it leads to organ damage. Remember that this organ damage develops over time, so the patient may not notice it until they have severe organ damage. Some of the more common signs and symptoms of just hyperglycemia in general are going to be things such as polyphagia, or feeling an increased hunger, polydipsia, increased thirst, so they might notice they're drinking a lot more water than normal. They feel like they always need to have some type of drink in their hand, or they have polyuria where they're noticing they go to the restroom more frequently. Of hyperglycemia will both be seen in DKA and in HHS. DKA is most often found in diabetic type 1 patients, and it's a life-threatening hyperglycemic emergency. The reason that DKA is most likely seen only in type 1 diabetic patients is due to the fact that DKA is caused to a severe insulin deficiency or no production of insulin. Because we have no production of insulin, the body cannot uptake glucose for fuel. So since the body can't use the glucose for fuel, the body starts to use fats for fuel through lipolysis. Lipolysis causes an increase in ketones, which causes an acidic environment, which causes the serum blood pH to decrease. The decreased production of insulin or no production of insulin also causes an increase of blood glucose in the serum, which then increases osmotic diuresis, or going to the or using the frequency of using the restroom, so it can actually cause dehydration in this patient. So DKA overall affects our body by increasing ketones production, which causes a decrease in the pH of our blood, while also causing an increase in blood glucose, which leads to dehydration in diabetic ketoacidosis patients. Due to the increased production of ketones causing the decrease in serum pH, as well as the increased blood glucose, which increases dehydration, signs and symptoms of DKA should not be surprising. These signs and symptoms of DKA occur quickly, usually less than 24 hours. The signs and symptoms associated with DKA are going to be things like dehydration symptoms such as nausea, abdominal pain, and vomiting. It can also cause hypotension and tachycardia. Respiratory symptoms are going to be rapid breathing, or also known as Kussmaul breathing, which increases the give-off of CO2 to try to help correct the serum pH, which also causes respiratory alkalosis. Urinary symptoms such as frequent urination, and then cognitive symptoms such as being unconscious or, at worst case, a coma. The last sign and symptom of DKA, which is one of the more hallmark signs of DKA, is the metabolism of ketones. So ketone metabolism causes the patient to causes the patient to have a fruity smell, and usually this fruity smell can be smell on the patient's breath. So when walking in a patient's room that might be a diabetic ketoacidosis patient, you would most likely notice a fruity aroma. I've been in many situations where a patient's been in DKA and they might not have known it, and I've heard physicians ask to have their blood glucoses checked because of the fruity smell in the room. When checking a patient's labs, certain labs should stand out for the diagnosis of DKA. Patients that have DKA are going to have a blood glucose of greater than 250 milligrams per deciliter. Since we are talking about the production of ketones in an acidic environment, the pH of the blood or serum should be less than 7.3. Since it is an acidic environment, bicarbonate should be less than 15 milliequivalents per liter. Osmolality should be less than 310 milliosmoles per kilogram. There should be an anion gap of greater than 15, and then glucosuria should be 4+. This should be no surprise since these patients should be having osmotic diuresis, meaning that they should be excreting glucose in the urine. Another lab value that is monitored for patients that might be experiencing DKA is ketones in the urine. Ketones in the urine can be checked two different ways. They can be checked over the counter using what we know as a dipstick, where the stick is put into the urine. There's a color change on the stick due to presence of ketones in the urine that can be matched up on the container of ketone strips to show whether or not the patient has ketones present in their urine. This is usually recommended for patients that have blood glucoses greater than 240 milligrams per deciliter. After they check this, usually if they have presence of ketones, they call their physician to find out if they need to come in for treatment or if it's a low enough level that they don't need to come in for treatment. In the hospitals and outpatient labs, they can also check ketones in the urine through a urinalysis and find the exact amount of ketones present in the urine. On your handout, there's an explanation for the ketone dipstick. Now that we understand the signs and symptoms associated with DKA and the pathophysiology and the lab values associated with DKA, let's discuss treatment of DKA. There are three parts to the treatment of DKA. The first would be fluid replacement, because these patients are going to be dehydrated. The second is going to be insulin replacement, and that's because DKA is caused by decrease in insulin production or no insulin production. And potassium and bicarbonate replacement is all going to depend on the patient's electrolytes. Some patients need it, some patients don't need it. But no matter what, all of your patients will always get fluid replacement with DKA, and they're going to get insulin. And remember, the potassium and the bicarbonate's a maybe. So when choosing a product for the treatment of fluid replacement, there are two categories in which we would not use normal products, and that would be for cardiogenic shock or hypovolemic shock. So we will not be discussing those treatments for DKA for those type of patients. So we'll be talking for treatment for patients with DKA that just have mild hypotension due to DKA. So there are two available categories of products that we will be using for fluid replacement. The first is going to be products with no dextrose, and then there's products with dextrose. The two products for no dextrose is going to be 0.9% normal saline or 0.45% normal saline, also known as half normal saline. The dextrose-containing products will be dextrose 5% with either 0.9% normal saline or 0.45% with normal saline or half normal saline. Every patient that's receiving fluid replacement will receive the same initial fluid replacement, and that first initial fluid replacement will be 0.9% normal saline infused over 1 hour. After the 1 hour infusion of the 0.9% normal saline infusion, they need to be reevaluated for the continuation fluid. The continuation fluid will be based upon the patient's fluid/cardiac status, the urine output, blood pressure, blood glucose, and electrolytes. If you're looking at your handout, you can see that you'll need to calculate what's called a corrected sodium. Based on the corrected sodium and their blood glucose, you can then choose an appropriate continuation fluid. So a patient that has a blood glucose of greater than 250 milligrams per deciliter plus a low corrected sodium value should get just 0.9% saline. If a patient would have a blood glucose less than 250 milligrams plus a low corrected sodium, they would need to get dextrose 5% plus 0.9% saline. So you can see that different blood glucose and corrected sodium is going to drive or going to influence which fluid you're going to use for the continuation fluid. Along with fluid replacement in these patients, we'll want to start using insulin in these patients to decrease their blood glucose. Now, insulin administration in these patients should be given IV or an insulin drip. Humulin R and Novolin R are your only two products that can be given through the IV for an insulin drip. Your goal for these patients is to decrease their blood glucose by 10% in the first hour. When starting insulin in a DKA patient, a bolus of insulin should be given first as an initial dose at 0.15 units per kilogram, followed by a 0.1 unit per kilogram per hour continuous insulin drip. Before starting the 0.1 units per kilogram per hour of the continuous drip of insulin, potassium needs to be measured. If a potassium is less than 3.2, you'll need to replace the potassium before starting the 0.1 units per kilogram per hour of the continuous drip. During the administration of the fluid replacement and insulin drip, blood glucoses and electrolytes should be being checked every 2 to 4 hours. And based on these blood glucoses and electrolyte checks, should determine whether or not an insulin drip should be increased so the patient would be receiving more units per hour, or it should be decreased so the patient would be receiving less units of insulin per hour. Each hospital has a different set of parameters for DKA or diabetic ketoacidosis patients, so it will all depend on the hospital you're interning or working at, what these parameters are for changing insulin drip requirements and monitoring. So once a patient meets the following criteria, they can go from IV insulin to sub-Q insulin. The 4 criteria that patients have to meet to transition from IV insulin to subcutaneous insulin is that, number 1, they have to have a normal anion gap, they have to have a normal blood pH, and they have to be eating, and they can have no ketones that can be detected on test. The final part of the treatment of DKA is evaluation of bicarbonate and potassium replacement. Remember, not every patient is going to need replacement of bicarbonate or potassium or both. It's all going to depend on the patient's original electrolyte reading when being diagnosed with DKA. When talking about potassium, remember that insulin drives potassium into cells. So if a patient would have a low potassium or hypokalemia to begin with, giving insulin could worsen the hypokalemia and could cause cardiac arrhythmias or heart problems. So for a patient who has a potassium reading of greater than or equal to 5, we would give no potassium replacement. For patients who have a initial potassium reading greater than 3.3 but less than 5.0, we'd want to give 20 to 30 milliequivalents of potassium to keep their potassium in the range of 4 to 5. And lastly, for a patient whose initial potassium was less than 3.3, we would give 40 milliequivalents of potassium per hour until their potassium was greater than or equal to 3.3. Once their potassium is greater than or equal to 3.3, we would then follow a potassium regimen of greater than 3.3 but less than 5.0 replacement, which was the previous slide. So when looking at bicarbonate replacement, there's only really one recommendation to actually use bicarbonate replacement, and that's only if the blood pH or the serum pH is less than 7.0. This is due to that bicarbonate replacement can worsen low potassium, so it can cause more hypokalemia, and it can cause cerebral acidosis. So now that we've gone through the pathophysiology, the signs and symptoms of DKA, and then the treatment of DKA, we'll now talk about preventative measures for DKA. For preventing DKA, recommendations to our patients are going to be things such as, number one is the most important, that's, use your insulin, be compliant with your insulin, don't go weeks without your insulin. Recognizing the signs and symptoms of DKA is also important for these patients to understand. Keeping ketone test strips available for when they have high blood glucoses that are elevated. And then 4 is communication with your physician or their providers when they have positive ketones or having these signs and symptoms. The sooner they would have the sign or notice the signs and symptoms in ketone or having a positive ketone test strip, and by the time they talk to their provider, the quicker they can be with that, the sooner they can catch it to make sure that the DKA is being taken care of and no other complications come from DKA. The second type of hyperglycemic emergency we'll be discussing is HHS, or also known as hyperglycemic hyperosmolar syndrome. Now, the hyperglycemic hyperosmolar syndrome is a life-threatening hyperglycemic emergency. Its mortality is greater than 10 times that associated with DKA, so it's worse than having DKA. And it's most often found in type 2 diabetic patients rather than type 1, which DKA, remember, was found more likely in type 1 diabetic patients. The pathophysiology behind HHS is a little different because we are dealing with patients like I just stated, that are type 2. So they have some insulin production. So enough glucose is being taken up into cells to prevent lipolysis or lipolysis from happening. So we have no ketone production in the patients. But we don't have enough insulin, so our blood glucoses are still elevated. So we have an increased osmotic diuresis, just like we do with DKA. So we have an increase with dehydration. So these patients are still going to be having the signs of dehydration, signs and symptoms, but they're going to be lacking those ketone symptoms that would be associated with DKA. The development of signs and symptoms for HHS usually takes days to weeks, so this process of HHS is usually over a longer period of time, unlike DKA, whose signs and symptoms usually developed in less than 24 hours. So the signs and symptoms associated with HHS are going to be your dehydration symptoms such as nausea, vomiting, abdominal pain, hypotension, and tachycardia. And then you also have some cognitive symptoms such as loss of vision, fatigue and weakness, confusion, and hallucinations. So as you can see, unlike DKA, who had the rapid breathing rate or the Kussmaul breathing and the respiratory alkalosis and ketones, HHS doesn't have any of those signs and symptoms. So you can imagine what the laboratory values look like for a patient diagnosed with HHS. The labs associated with HHS are going to be things such as a blood glucose of greater than 600, a pH greater than 7.3, bicarbonate greater than 15, osmolality greater than 310, an anion gap less than 15, and glucosiuria 4+. So you can see there are some similarities between DKA and HHS, and there's some differences, such as your blood glucoses are going to be greater in HHS, your pH is going to be greater in HHS, and this is because we're not producing the ketones or the acid environment. And since you're not producing the acid environment, your bicarbonate is also increased as well. Treatment for HHS should look very familiar to you. Treatment for HHS is very similar to DKA in that we're going to be looking for fluid replacement, insulin replacement, and we're going to be looking for potassium replacement. The differences between the DKA and HHS is that you do not see any bicarbonate replacement in HHS. Potassium replacement, just like in DKA, is all going to depend upon the patient's initial potassium level. Since there are a lot of similarities between DKA and HHS, I will be just going over some of the differences between HHS when comparing it to DKA. So for fluid replacement, you're going to use the same initial dosing for DKA. The only difference is that you will switch to dextrose when their blood glucose falls below 300 milligrams per deciliter. This is the hope to help prevent hypoglycemia from happening, since the patient's been used to elevated blood glucoses for a long period of time. For insulin therapy for HHS, it's going to look very familiar. The dosing is the same as it would be for dosing for a patient with DKA. The only difference is that you're going to be trying to reach a goal of decreasing the blood glucose 50 to 70 milligrams each hour. Potassium replacement in HHS is going to be exactly the same as a patient that would have DKA. So for the treatment in HHS, please refer to your notes for DKA and potassium replacement. Just like with DKA, prevention is important in HHS. Prevention tips in HHS are going to be things like making sure your patients are compliant with their medications and making sure they understand why they're using their diabetic medications, and explaining to them that skipping or not using their diabetic medications can lead to HHS, and educating your patients on the signs and symptoms of HHS early may help prevent the mortality rate associated with HHS. This concludes our discussion on hyperglycemic emergencies, DKA and HHS. I would like to thank you for listening to the video. Before class on February the 20th, I would like you to complete the comparison chart of DKA and HHS. This will be turned in at the beginning of class on February the 20th. Once again, if you have any questions, please feel free to email me at joshua.kane@promedica.org. Thank you once again.